this week on the BackTable Podcast.
So I think that for me, the GURS meetings, both the standalone and the meeting at the annual AUA meeting, are probably my big high yield things for stuff that might move my clinical practice. I still think that the research and the content that will push me to maybe ask a research question that I wouldn't have thought of is the poster and podium sessions at the annual meeting of the AUA. That's the stuff that, from a research standpoint, it's still mostly academic program-driven research as opposed to the GURS meeting, which is like, this is what we're doing in the specialty right now from a clinical standpoint. So they both certainly have their value, but I would say the thing that pushes my clinical care forward is the GURS meeting.
Well, let's get into it, George. I guess let me ask you. You've been on BackTable a couple times, which is awesome. Do you listen to podcasts yourself, or did you appear first and then start listening?
I was a BackTable listener a lot, maybe 2 or 3 years ago, and especially when I was a resident at first, when I felt like BackTable was coming on the scene. I listened to it a ton. I definitely phased out a little bit during my fellowship year, but I was a fellow who took a lot of call. I was a urologic trauma fellow. I was essentially on call for like a whole year. So I pretty much phased out all media at that time. Yeah. But then, as an attending over the past, I'm almost 2 years in, and I've started listening to it a lot more. I was just listening to the urology show has an episode by Ann Cameron about like how to say no, but it's like how to be smart about your commitments. And I'm really enjoying it. I'm like halfway through right now. I listen to it on the drive all the time.
Okay. And so that's your go-to, is it kind of on the drive?
Yeah. I have 2 dogs as well. So on the drive or walking the dogs, I kind of always have, 15 to 20 minutes a couple times a day of quiet time. And if it's not a podcast, then it's an audiobook. Just, I mean, in today's day and age, we kind of always have something going, right? Like some sort of screen, some sort of audio, something. So I don't sit quiet well.
Well, there are worse things you could be doing than educating yourself and learning while you're being idle. Yeah. But content like this, is that a viable way to keep up with the field, or is that supplementary to, the core learning?
I think it's gotta be supplementary. I don't think that anyone can pay attention to any medium all in one. And it's sad too, because, I was a medical student right around the time when we started like switching to iPads. And so I remember like reading, like printed out books, printed out chapters, like writing down on my slides. And now I sit down and I read a journal article, and sometimes it can be difficult for me to like get through it without getting distracted. Same thing for videos, same thing for audio content. So, I think that you really have to kind of hit it from every angle and know where you can get some efficient lessons. That's one thing where I think BackTable does a really nice job of is you can go to BackTable for brush up on a topic. You can go to BackTable for like a very deep dive into a topic, depending on kind of what the episodes are. But it's got good breadth and depth. And the show's been around long enough where you can really search back through the archives and kind of pick what you need.
Well, love hearing that. Appreciate the kind words. And I guess when a new paper drops, say on urethral reconstruction or Fournier's management, how do you find out about it? Is that a journal alert, a colleague texts you, Twitter, BackTable, a variety of other outlets?
It used to be the paper journals. I up until last year, the Reconstructive journal, my subspecialty, and then the landmark journal for our specialty, the Journal of Urology, were both still paper print coming to the house. Like they would get there, I would sit down with coffee on a weekend and go through the table of contents. Now, I do find it a little bit harder as journals are moving towards being, digital first or digital only. And it's a little bit of everything. It's word of mouth, and then I look it up. It's journal alerts that kind of I've set on the computer. Sometimes it's when I'm talking to someone, for a BackTable episode, and they mention something. I'm like, oh, I got to go look that up later. So it is a little bit of everything, and I do find it hard sometimes to really like I know I used to be able to rely on the table of contents of my journal showing up, and I really now have to be cognizant about going out and fetching some of that information, because it's not kind of delivered to me on a platter anymore.
Well, it's funny, like you say that. I mean, yeah, when it was in print at your house or in your office, like you said, you could grab a cup of coffee and just sift through the table of contents and then see what you want, get into what you wanted to get into in a way that was actually unique because it stood out from everything else.
Yeah.
Everything else is in your email inbox or another type of alert.
Yeah. One thing that I really still value and love, and I definitely want to make a plug for, is so at the end of the Journal of Urology specifically, there's a thing called the surveys section where there's like a thought leader for each subspecialty in urology, and they pick 3 journal articles and essentially write, a little synopsis and kind of what this made them think of, halfway, somewhere between like a journal club and an editorial. It's in the back of every JU, and the Reconstruction one is written by Sean Elliott from the University of Minnesota, and I absolutely love that section. It is my favorite. It's the thing that even when I forget to like check back to see like what's in the table of content of Journal of Urology, I always remember it's one of my journal alerts to see that drop. But I love that section. It never gets enough love. I try to mention it whenever I can so that people go and visit it. But it's the urological survey section at the end of the Journal of Urology, and it is some of my favorite content to read.
And why is it your favorite?
Because it's the way, at least for Reconstruction, Dr. Elliott writes his are very conversational. They're not strict, and that's why I say they're kind of halfway between an editorial and a journal club. It's because it's not straight like this is a summary of the article. There's a lot of like, this is a summary of the article, and this is what it made me think about for my practice, and this is how you might be able to incorporate it into your practice. It's almost as if you're getting to have a discussion with him about it, and you can kind of see him trying to answer the questions that he thinks people might have as they're reading it. It's not all new papers. Like this most recent one had a paper from 2024, which is like not that old, but he does a good job of calling back like, these 2 papers are related and this paper is also related. It was from a couple of years ago, but it, made me kind of think of it. So I always love that section.
You're making it sound good, George. I want to go read it.
I couldn't recommend it more. I absolutely love sitting down with the journal when I can. And that's a great way to get, in a page and a half to get 3 articles plus the thought behind some of it. It's efficient, it's enjoyable. Highly recommend.
And you're still on the editorial board of the journal, is that right?
Yeah. I'm one of the early career editors. I'm in my last year doing that. I hope to stay on in some capacity afterwards. It's, I think, something that came about because of my, love for print journals and my love for like, disseminating the evidence and thinking about the evidence and thinking about how to disseminate the evidence. That's one of my my favorite things that I do, in academics.
I mean, you got to review the papers as being on the editorial board. Then you're going to review papers. So I guess, maybe it's just you've already reviewed a lot of the papers, I suppose, or some of the papers that are relevant to your section.
I do. The lag time between like when I've reviewed them and when they make it to print is enough time where I've kind of internalized the message a little bit, but I have a chance to forget some of the particulars. So I still enjoy kind of going back through them. The urological surveys section portion is totally to that editor. So I don't even see that portion. So that's always new no matter what for me. But even for the recon stuff, I still kind of get a chance to brush up on the articles. And then all of the editorials are chosen by the editor above me. So even if I remember, the paper word for word, which I never do, the editorials that follow it are still brand new to me. So I still get a kick out of it.
And so going back to what we were talking about earlier for a second, is there you had said, I mean, you can't have one single go-to source. So
Yeah.
is there a home base for you that keeps you current, or it's everything?
It's a little bit of everything. I have a very subspecialty practice now. So, as far as content that's like affecting my practice, I will go out and do a PubMed search every once in a while or check Twitter or X, excuse me. I do a lot of the recon episodes for BackTable, so I kind of know when those are coming out. But I'm out looking for content and I kind of know my spots where I'm going to find like the things that are going to be relevant to specifically my patient care delivery. And then for my research interests, you're kind of always keeping an eye on what's new. My big research interest is Fournier's gangrene, and I'm always looking to see like what's coming out and what can kind of inform the next project. But it really is a little bit everything. I've like cold searched Spotify and Apple Podcast for Fournier's gangrene, which is not a fruitful search term. But I'll like Google, I'll PubMed, a little bit everything.
LinkedIn
LinkedIn is not one that I've ever personally used, but I mean, I don't see why not.
Yeah, I gotcha. But it's not like there in the way that you need it to be there.
It's not one of my go-tos for sure. I'm excited. I know that BackTable is or has an app. I need to explore it more, but I am excited that like that could be kind of a landing page or a place where stuff consolidates. I haven't quite worked it into like my rotation of stuff that I look through yet.
This was maybe a little earlier, but I know that like Twitter, when it was Twitter, had its moment.
Yeah.
And then kind of what I've heard anyway is it kind of fell off. Like it's not like that anymore. Curious whether you were on it when it was big and whether you also kind of came off of it.
I think you had to be on it when it was big, unless you were like, obviously your thought leaders, your professors, like I'm sure that they weren't like heavily on Twitter, but Twitter definitely had its moment mid-residency for me. Maybe a couple years before COVID, and then really was very helpful during COVID because it was kind of a good source for community, especially for residents, medical students, attendings trying to recruit those, residents and medical students. So I was definitely part of it. I think that people like begrudgingly had a Twitter even if they didn't want to. I know all of my co-residents my year at Vanderbilt had a Twitter. Some happy about it, some not. But it was super useful. Like people posted, article updates and tried to use it as a place to make sure that they were, disseminating their work. It definitely has fallen off. And I don't know that I have like a great moment for when it did fall off, but there was definitely a hot few years in like Twitter where it was a really, really useful academic community building tool. It was good for research dissemination. It was good for recruitment. It was good as a community. And I don't know when it quite petered out, but I definitely, I still have an active one. One of our faculty at the Ohio State, I use the article.
Nicely done.
Thank you. Always make sure to like post our residents' work on there. Every month or two, I'll like jump on like all of our posts and then jump off. But I don't use it all that much anymore for urology.
And is that because it stopped being just like you lost interest or stopped being as useful to you? Or do you think it actually had something to do with the platform itself, the content that was on there, that it kind of like everybody lost interest and therefore you lost interest? You know what I'm saying?
Probably a little bit of both. When it started to peter off were my like senior years in residency and then my fellowship year, which were for very good reason, kind of all encompassing. Like you were kind of in it in the clinical medicine as a chief and as a fellow. So, I just stopped using it. But I also think that it probably was also losing steam as a community at that point. I stopped using it because I was super focused on clinical work at that time and nothing drew me back to it. So probably a little bit of both.
So we were talking about Journal of Urology.
Mm-hmm.
which is an AUA publication, right? And
Yep.
then there's the GURS. I guess there's Society of
the gold journal or urology is the official journal of and nobody get mad at me for forgetting, but it's definitely the official journal of GURS, the Reconstructive Society. It's the official journal of Society of Women in Urology, SWU, and I think it's the official journal of the Society of Academic Urologists.
Okay.
And I'm probably missing another one. But yeah,
Okay.
it's a kind of a multi-affiliated journal. And it's one of, I would think of them as the big three, like the Journal of Urology, European Urology, and the Gold Journal at least for US readership.
The Gold Journal is urology. Is
Yes.
that
Yep.
right?
Yeah.
Okay.
Urology, all capitalized urology.
I guess the AUA annual meeting versus the GURS gathering, like which is more, I guess, like which moves the needle more for you in your specialty, would you say?
Within our specialty, so GURS, we're lucky enough that we have kind of a standalone meeting and we have a day at the AUA that is kind of devoted to GURS. I think content that actually pushes my clinical practice, makes me think about trying new things or looking at disease process a different way. I think that's probably the GURS content. That's when it really is the most clinically applicable. They do a really good job of generating good discussion. They've got, kind of a good mix of thought leaders and up and comers. They do a lot of video reviews so you can actually see some of these things and how you might be able to do a surgery robotic that you were doing open, that kind of thing. So I think that for me, the GURS meetings, both the standalone and the meeting at the annual AUA meeting, are probably my big high yield things for stuff that might move my clinical practice. I still think that the research and the content that will push me to maybe ask a research question that I wouldn't have thought of is at the annual meeting, the poster and podium sessions at the annual meeting of the AUA. That's the stuff that from a research standpoint, it's still mostly academic program driven research as opposed to the GURS meeting, which is this is what we're doing in the specialty right now from a clinical standpoint. So they both certainly have their value, but I would say the thing that pushes my clinical care forward is the GURS meeting.
And at GURS, is it more like the sessions or is it the conversations happening between sessions and, after hours, what, or both?
I think it's probably the sessions and the content are what make me change or reinforce or stop doing things from a clinical standpoint. But the conversations that I have between sessions and after sessions are probably the thing that make me so excited to go to the meeting. I mean, getting the interface with people, getting to catch up with folks, I really would like to make it a habit early in my career of kind of visiting people at other institutions, getting a chance to see how they do it. I've been very fortunate to have a couple of opportunities to do that early on. And that kind of interface, seeing another surgeon operate, getting to pick their brain between cases, having a meal with them has really, really made a huge impact on my practice, really kick-started it. It was after both of the times that I've gotten to observe or work with other much more senior, much more experienced reconstructive surgeons, I felt like I was shot out of a bottle rocket for the next couple months clinically. It's been such a pleasure.
Medicine is pretty unique in being as complex it is and as apprenticeship style as it is, whatever the right word is. I'm sure there's a word for that I don't know.
Yeah.
But you kind of do have to apprentice to learn it, and you kind of keep that apprenticeship going in a way. I mean, not in the same way, but that's how it works.
I couldn't agree with that more. I just actually took at Ohio State, I took a course on curriculum design, and our final project was to kind of present our curriculum. And as I was laying it out, it's a big curriculum to teach people how to do bulbar urethral surgery. But when you really get down to what that actually consisted of, it was really just guided mentorship, because you're right, it is still, for all of the education that we can do in surgery, you still when you're working day to day and when you're learning day to day, you're learning from another surgeon, like hands to hand, whatever way you frame it, that's still the way we're learning cases.
Yeah. And
And when it
I
works,
suspect it'll be that way for a while. Yeah.
yeah. And when it works, it's a beautiful thing. It is a fulfilling thing. You make a personal connection. You can, like, giving mentorship and receiving mentorship can both be like so invigorating and exciting when done well. So for my curriculum, I hope that it helps kind of guide people through that process.
I suspect that is part of what builds the community of physicians. Do AUA, if you're in a physician community of reconstructive surgeons, was that more GURS or more AUA or both? Like, how do you think about that?
GURS does a good job, I think, of interfacing with the AUA. The AUA, at least I think of as kind of the big governing body. It's like where the guidelines come down from. But I think that if I'm about to like start a group thread because I've got a complex case and I want to like talk to some other people to think through it, I'm not thinking of like who are the AUA folks. I'm thinking of like who are the GURS folks. I like have a couple text threads that are like young GURS, youngest GURS. Like that's definitely the community that from a reconstructive standpoint I'm kind of looking around at. The AUA it's not that it's not a community, but the AUA is just it's like if I want my road fixed outside the house, I'm going to like the city of Columbus. I'm not going to like Washington. That's kind of how I think of like GURS versus the AUA,
Okay. Good analogy.
Yeah.
So maybe last topic here, when a company has a new device or approach relevant to reconstruction or trauma, say catheter or graft material scope, similar question, like how do you learn about this? Is this reps, conferences, literature, peers?
I would say that it usually starts, at least in recon, it usually starts in conferences. And that might be some industry sponsored stuff. Usually it's like one or two reconstructionists are trying something new. And then we all kind of pull them aside at conferences after they've given a talk and figure out how to implement it ourselves in our own practice. But I think that conferences are still the big place where we're seeing that happen. Devices in reconstruction, they're very hard to research in like a super high quality way, which isn't to say that high quality research isn't being done, but so many recon patients are so unique that I do think that it can be tough sometimes to craft in inclusion and exclusion criteria for studies. So normally when we're like trying something new in recon, a lot of times you're looking at like small single surgeon case series and they've either partnered with industry or invented something themselves. And it starts off as like a small single surgeon case series or single institution case series. Then it'll get presented a couple of times at GURS and then it really starts to catch on within the community. It's very rare, I would say, Optilume being kind of one of the biggest exceptions, which is a chemotherapy-coated dilation balloon for urethral strictures. I would say that it's pretty rare that we see like a randomized control clinical trial that comes out in recon, and that's when people start adopting. Usually it's, I've seen a video of someone do something, really cool and innovative. I think I can do that technique at my institution. And then like I said, pull that guy aside at a conference, call them, email them. The great part about GURS is most people are pretty open to giving out their cell phone number, giving out their email, talking about cases. A couple of years ago, I was just putting together a lecture when I was a fellow at the University of Washington for my residents, and I really wanted a video of this new endoscopic stricturoplasty technique that a guy named Nick Warner was doing at Mayo. And I emailed him just to see if I could get like a little snippet. And he sent me so many like really high quality surgical videos and then invited me out to come to Mayo and see him do it if I ever wanted to do it, and I would say that is the rule in reconstructive urology, not the exception. Like people really, if someone thinks that they have like a hot new thing, they are not trying to protect intellectual property or like make sure they get their name on it. They're like disseminating it so that we can all use it to help patients. So it's we're fortunate.
Is that unique to reconstructive urology, you think? Or
I hope that it's not. I am so thankful that I don't have to go, no offense to endourologists, but I really don't like treating kidney stones. I'm very thankful that I don't have to go to the endourology meeting. I wouldn't understand what they're saying at the oncology meeting. So, I hope that it is not unique to reconstructive urology and that it's something that's universal within urology. But the only thing I can say for certain is that in reconstructive urology, like I said, like generosity of spirit, generosity of idea, try to help everyone do the best thing for the patients is absolutely the rule.
It's cool.
which is great.
Yeah, that's great. When information comes from industry, what's the difference between the stuff that's useful and the stuff that feels like noise?
The difference between useful content and noise is oftentimes, am I hearing it from a source that I trust? And what medium is it being given to me? I think a great example, I do a lot of like skin and soft tissue surgeries, so buried penis repairs, and then I take care of a lot of wounds, both for my service and for patients who come with Fournier's. And I often get pitched like, oh, try this new dressing, try this new graft substitute, try this new like biologic thing. And oftentimes the reps will, pull me aside as I'm like walking down the hall, and I'll get a case report that is like 2 patients over 20 years in a disease process that's not super related. Those very rarely make an impact on like what I'm going to do for my patients, and they very rarely like catch my attention. If I am talking to a reconstructionist who is doing something and they've done a few of them, and then I trust their work, and they've, got some photos and they've published, and I know that it's a disease process that I treat, then I'm much more likely to use it in that scenario. A good example is for Fournier's, at least a couple of years ago, Kerasis, which is like this fish skin graft substitute, was kind of hitting the market, and it's now used in a couple of different applications within urology. But when I talk to folks, I haven't used it personally, and I keep meaning to, but when I talk to folks who are using it, who I trust as surgeons and who I know are using it in the disease processes that I treat, I'm much more likely to adopt it than when I get pulled aside and get shown, like I said, a kind of a half-related case report, and I get some, half-related information.
Well, it makes sense. I mean, as somebody who's spent a life in sales, sometimes you'll say anything to get somebody's attention. whether or not you should.
Yeah. And I don't know that anyone's ever tried to lead me astray, It's just, it's very, it's without understanding the basic science of wound biology. And I have some understanding of it, but certainly not like a device development, biochemical engineering background in it. Like I said earlier, I was a history major. I kind of understand the basics of wounds, but I don't understand them at a super, super nuts and bolts level. So it just doesn't move the needle for me when you tell me that this changes my ratio of nuts to bolts. It much more moves the needle when I talk to, I talked to Shubham Gupta, Case Western, and he's used this for 3 of the exact same patients that I'm going to see, and he's had great results. And then that's when I start to say, oh, I wonder what the science is behind this, But it just means a lot more coming from someone who I know who's used it in my in my area.
Makes sense. Makes total sense. I mean, that would be trusted, from somebody in the community.
Mm-hmm.
Thanks for joining us here, George.
Yeah, thanks for having me.
I hope to run into you when I'm at a Michigan-Ohio State football game or something like that. And
absolutely. It's at the Shoe this year. I've got faculty tickets. Looking forward to it.
Awesome. Thanks, bud. I appreciate your time.
No problem. Thank you. Thanks for having me.
All right, guys, thanks so much for listening. If you haven't already, be sure to follow and subscribe and rate us 5 stars. Also, share with a friend. If you do, who knows, there might be a BackTable hoodie in your future. If you have questions or comments, DM us. We're @_BackTableIND on Instagram, LinkedIn, X, TikTok, and Blue Sky. BackTable is hosted and produced by myself, Anish Parikh,
and Ruchika Talwar.
Our production team is led by Kieran Gannon,
Aaron Bowles,
Gabe DeGrazio,
and Josh Spencer.
Design and digital marketing led by Brian Schmitz.
Social media and PR by Ann Dang.
Administrative support provided by Judy Dela Cruz.
Thanks again, and we'll see you next time.